Hello, I'm Bob Falcone, CEO of the Columbus Medical Association and its affiliates. One of those affiliates is the Central Ohio Trauma System, which in mid-March was tasked with helping to coordinate our pandemic response for our region. And that region includes Central Ohio, Southeastern Ohio, and Southeast Central Ohio. It's also known as Zone 2. Good news first. Our COVID numbers have been decreasing. Our hospitalizations have been steadily decreasing. And it seems to me, looking at the data, that the severity of those hospitalized is less. Especially important using the governor's grading scheme of yellow, orange, red, and purple. Franklin County is now orange, and most of our region is yellow or orange. All good news. Today I have Bruce Vanderhoff with me. He's CMO of the Ohio Health Organization. Bruce, welcome.
Thank you. Glad to be with you.
Are you seeing the same things at Ohio Health as far as the COVID numbers?
Yeah, we really are. As I look at the data on a daily basis and then compare it to Zone 2, we're really almost a perfect microcosm of Zone 2. You could almost take the Zone 2 maps and graphs and say, you know what, that's Ohio Health, just slightly smaller.
Well, you cover most of Zone 2.
We cover most of it. Yeah, that's right. Yeah,
which is phenomenal and I think really good for the communities.
Yeah.
I'd like to talk a little bit about testing. You know, a couple weeks ago, we had a serious hubbub in the media and in the medical community when our governor tested positive for COVID, but he was asymptomatic, got retested with a confirmatory test, which was negative on 2 occasions. So he had a negative test. What happened?
Yeah, what happened there was that he was tested using an antigen test, as opposed to the tests that we've been talking about now for months, which are molecular or RNA amplification tests run on PCR machines. That test was one of the new generation, one of the earliest releases of the so-called antigen tests that are very much like a pregnancy test or a rapid strep test. The nice thing about those is they require, of course, far less infrastructure and technology. Nice thing is that they really bring whatever testing they bring to the table much closer to patients and to the front line. The downside is, and we know this from strep tests, they need to be applied in the right setting and with the right understanding regarding their sensitivity and specificity. Their false positives, false negatives. In his case, he's asymptomatic. The test that was run, in my estimation, probably there was an issue with contamination. I don't know that for sure, but I think that that's a probability with the test showing positive and yet PCRs coming subsequently not showing him to be positive. So honestly, I think it was a test that was maybe not quite ready for prime time.
Yeah, and there's more than one type of
Yes.
saliva test or spit test. There's also a genetic form of that test, right?
That's right. That's right. And we've heard a lot in the media recently about the really good work that's come out of Yale, where they were looking to try to solve a problem. They looked at the country and said, healthcare providers, institutions, even states are running into challenges with access to reagent, access to the supplies that are needed to run these PCR tests. Is there something we could do that would make it provide an option for people who've run out of a particular reagent to still be able to run their tests? Is there also something we could do that would make collecting these nasopharyngeal samples unnecessary? Because the other supply that people tend to run out of are those swabs. So they were looking to solve both problems, and they came up with a protocol. And that's really what that saliva test is. It's a protocol that would allow labs to take samples that were saliva samples, so essentially spit into a cup, and run those through a PCR process regardless of what reagent you had on hand. Sounds great. Sounds, in fact, like they've solved the problem. Turns out, though, that's a little more complicated than that. Yes, you can do it, but it requires much more lab personnel time. It's very labor intensive to get those tests run through and to make those necessary adjustments, et cetera. So we did an analysis at Ohio Health to say, well, could we make a switch in that direction? And as it turned out, if we were to do that, it would actually, because of the increased labor that's involved, and these are, not people in huge supply, these are highly specialized lab personnel, it would have driven the cost up, and it would have extended the time for us to turn these tests around considerably. So for us, it's just not a workable solution, and I suspect that's true for many.
And as I understand it, the tests that we were currently using in Ohio to kind of mass screen nursing home patients had an enormous false positive rate. Well, I can't think of anything worse than telling somebody had COVID, getting everybody stirred up, everybody moved, everybody isolated, and confirming the next day that it was a false positive. That cannot possibly help save any time, money, or lives.
No, and so now I think these point of care tests, people are beginning to look at them in a different way. And I think we're recognizing that there is going to be a place for point of care testing with COVID, but it's got to be in with a couple of requirements or caveats. First, their most ideal use is in the setting of a healthcare provider providing oversight on their use, i.e. your primary care doc, being able to say, okay, look, we just got this positive test on you. You are symptomatic. I would have guessed that you're positive. That information together with the positive test probably means that it's pretty good. As opposed to, if we're going to use them to test institutional populations, we've got to recognize that what they're going to tell us is something about the environment, not so much something about the individuals in that environment. If we want to make individual diagnostic decisions, we're probably going to have to get a backup PCR.
And when you think about it, that's basically the way we practice medicine. We have a clinical suspicion, and we document it with a test.
That's exactly right.
If the test doesn't document the suspicion,
yes,
we might do another test.
Exactly right. And for screening large populations, nursing home populations, well, those point of care tests might not be a bad option to get a gestalt. But they're going to tell us, okay, we're getting some signals from this place that now we have to come in and do some of the more diagnostic testing to find out who is actually infected.
The CDC stirred up quite a ruckus lately, as you know, suggesting that asymptomatic people, even if they've been in contact with a known COVID positive person, don't necessarily need to be tested unless they're a healthcare worker or unless they're personally vulnerable. What are your thoughts on that?
I think the CDC was really attempting to do a good thing and to recognize some of the clinical practice that's actually happening around the country and is legitimate. And that is that not infrequently, there are circumstances where people are contacting their physician and they are essentially painting that picture and saying, hey, you know what? I was exposed to somebody who was just tested positive. I feel fine. Should I run out and get a test? And the doc has said, well, you know what? I know scientifically that it actually takes a little bit of time before that viral load goes up enough that the test is even going to be positive anyway. Why don't you quarantine? Why don't you just self-quarantine? Let's see if you develop symptoms over the next several days. If you do, let's definitely go ahead and get a test. If you don't, you've probably got the option of quarantining for the full 14 days or get back to me. Maybe we can talk about testing then. And they've been doing this in the context, thankfully, and I'm really appreciative of our medical community doing this, of recognizing, look, these tests are not in abundant supply. So let's be thoughtful about when we're testing people. And I think the CDC was trying to say, hey, you know what? Clinical judgment is appropriate to apply in this scenario. Unfortunately, the way they put the message out there was inartful, and it created the misperception that we don't want to test asymptomatic people. And that's not true at all. We very much would like to get to what our state is defined as level 5 testing. It's just we've had problems with access to tests.
But I think the message is clear. Testing in the absence of some kind of clinical intervention is probably less than effective.
Yeah, it's going to be, and we all know this from all the other laboratory tests that we've run, it's going to be low yield. And so we have to be really thoughtful about what is it that why are we doing it? And what are we going to do with the information if it comes back positive?
So, as I said earlier, Ohio Health has a huge footprint in central, southeastern, and southeast central Ohio. What are you all doing for testing? What's your gold standard currently?
So we, at this point in the game, are not using any of the antigen tests. The antigen tests that are available now are still in very narrow supply. They're not easy to get.
And they test parts of the virus.
Exactly right. These are nothing really any different than the rapid strep test you might be running in your office. So those tests, I think, will become more widely available in a period of months, but right now they're not widely available, and we're really not using them. We're using the traditional big PCR machine that's used to run PCRs for all kinds of different reasons and samples, one of which we are able to run samples for COVID-19 or the SARS-CoV-2 virus on our big machines. So think of the big lab machines. The other is we have the Abbott test. It's still doing RNA amplification, but it's just for SARS-CoV-2 or the COVID-19, the virus causing COVID-19.
Early on, I think all the Central Ohio institutions were testing their pre-op procedure patients and their admissions. Are you still doing that?
Yes, we are. Yeah, we are. I'll tell you one of the interesting innovations, though, that we're looking at, because that population has a very low rate of being positive. When we look at those populations, we're typically talking about less than 1%. Of the samples coming back positive.
Compared to Ohio's current rate of about 4.2%.
That's right.
So
right. So,
which is low. But
but this is even lower. So
okay.
These are very likely to be negative tests. And the FDA, not too long ago, has allowed for what's called pooled testing, where essentially we take samples from multiple people, 4 or 5 people, depending on what a lab has been approved for. And we essentially do pooled testing. The nice thing about that is it cuts down the use of the reagent, the supplies that are necessary to run these tests. And as long as it's negative, we're golden. We don't have to do anything further. On those rare situations where one of those is positive, we do have to go back and ask those 4 people for another sample. But again, that's very rare, and it's really allowed us to extend the supplies that we have. And we're not the only ones doing it. Other institutions, I believe, including OSU, are also doing it.
And you're doing that now?
We are.
Okay. That to me makes complete sense when you're talking about a relatively low yield.
Yes.
Just test everybody. If they're negative, and move on.
And move on.
Yeah, which makes complete sense. One of the things Ohio Health is responsible for in its areas of healthcare are institutions of higher learning. Ohio University, for example, is going back to school.
Yes.
How are you dealing with those kids? What are you doing?
Well, we have a special relationship with Ohio University, have for quite some time now. And so as they were developing their back to school plans, they really turned to us for help as the healthcare provider. People may not be aware, but down in Athens, Ohio, that's where the main campus is, and we are the main provider. We have the only large hospital in town. And we're also the student health provider. So we're already plugged in, and one could really make the case that because of our strong primary care presence, the hospital, and our involvement with student health, we're kind of on the hook anyway for providing care for people who might become sick with COVID-19, including students and faculty. So with that in mind, we really worked and this was kind of hard work because it's new to the university and it's new to us. But we worked very closely with them to see how could we support their efforts to get back to school. The way that we're doing that in a nutshell is, first, we're making testing for people relatively easy. We've essentially set up the same kind of testing capability there that we have up here in Central Ohio at our drive-through locations. On the campus, it's not a drive-through location, but literally a tent right now where we're able to safely test students. Students and faculty who either are concerned about an exposure or have developed symptomatology are able to be put through that. The university had already worked with its student population to have them test negative, I believe, before coming to the campus. So we didn't have to get involved with that aspect of the initial screening. But then there are also issues of, well, what does one do once one's had the test? And so we've worked closely to support the university in providing students and faculty with guidance if they have had an exposure or they're symptomatic regarding quarantining. Okay, what do you need to do? And then in supporting the university in monitoring the students, because while students are young adults, they're sort of in that transition zone.
Emphasis on the young.
Yeah, that's right. They're in a transition zone, and there is a level of responsibility the university feels towards those students and making sure that they understand what needs to be done and feel supported in doing that. So we also are plugged into providing what I would call care management. And those care management resources between us and the university include things like making sure they can get food, making sure that their basic needs are being met while they're quarantining. And then the last thing is we're poised to be able to intervene should there be a dorm outbreak. So we're monitoring very closely, and were a positive test to occur for a student, we would identify which dorm they were in and then be able to go in and test the members of that dorm.
How is the university doing?
I think they're off to a very, very good start. They understandably were very concerned to make sure that they had all the pieces and parts in place and could really provide an environment of safety for their faculty and the students who are coming to the campus. But so far, and I'll knock on some wood here, so far so good.
That's great. For a while, our high schools were talking about testing athletes every week. Yeah. Are we still doing that? Are you doing that?
Yeah, we're not. I can't speak for all of the high schools around our communities. I can tell you that I think there's a growing recognition that that's not really very practicable.
Or productive.
No. So I think more and more what people are doing, and thankfully there's been really good guidance that has been emerging from some of the athletic associations and from some of the education associations. For example, music education, where there is actually a national body, and I'm going to get the acronym wrong, but I think it's NFHS. I'm pretty sure that's right, the NFHS. And that national body has been pulling together all the scientific literature and information around the various educational endeavors, including music education, to say, well, what are the safety steps that a band director, for example, really needs to entertain in safely delivering education to these students? And I, along with people like Joe Gastaldo from Infectious Diseases, and frankly, doctors from all over our state, have provided them with guidance about that literature and guidance about those recommendations. And I think people are now, because of that kind of development, I think they're really moving down much more practical pathways in terms of providing a safe environment. So social distancing is possible. in bands, thinking about an outdoor environment as different from an indoor environment, recognizing that there are pretty simple things you can do with instruments, like putting essentially the material that's used for pantyhose over the bells of instruments, in addition to playing with a mask on, which actually at first I thought, well, how could you play with a mask on? Well, simple solution, they cut a little slit for it to go in the mask. And apparently that really makes a big difference when they have looked at this inside of controlled environments.
Wow, that's pretty amazing.
Pretty amazing.
Winter's coming. You have a number of drive-throughs,
Yes.
tents.
Yes.
You work with City of Columbus Public Health to help staff their drive-through.
Yes.
What are we going to do in winter?
Well, we're actively together as a region looking very carefully at that and examining a couple of different potential scenarios. One is that we've been working together looking at the fairgrounds. You know, they've got big buildings there.
Franklin County Fair.
Franklin County Fairgrounds, the state fairgrounds. And they've got buildings that are actually designed for motor vehicles to come in and drive around inside them with crowds in there. So could we utilize spaces like that to provide continued drive-through care while also keeping the providers relatively warm? It's not going to be like being in a room like this, but better than 20-degree weather. So that's one option, and we're looking at that. There's some benefits and shortcomings to that. One of the shortcomings is it's one centralized location. The further out one gets, and one thinks about an organization like Ohio Health covering 47 counties, that may not be adequate as a sole or maybe even preferred solution. So another thing we're looking at is, can we winterize the tents that we have right now? And we're actively exploring an option that essentially involves containers, those big containers, which people have done fabulous things with those. Those can be modified to essentially have be connected to a tent, provide a nice environment, and then the person testing you essentially just sort of steps out, tests you, and then retreats back into their nice temperature-controlled environment. With the tents, of course, we today have the ability for radiant heat that can help cut that down. And we've probably all experienced that at restaurants where that radiant heat really does make a difference. So we're looking at solutions of that type.
We're approaching flu season. Two things I want to touch base on. First of all, how do you perceive us dealing with flu and COVID? For example, if a person comes in with flu-like symptoms, do they get a COVID test? And if that's negative, you assume it's the flu? Do they get a flu test? And if it's positive, you assume it's not COVID? Do you do both at the same time? Do you have a feeling for how that's going to work?
Yeah, we've been actively thinking about that with an eye towards being able to provide clear clinical guidance as we get a little closer to flu season. First, careful surveillance, which we do every year, very important, because being able to convey to the provider community, all right, here's what we're seeing in the community, really helps with that clinical decision making. Am I looking at flu? Am I looking at COVID-19? At first, we're going to have, in my opinion, no choice but to do dual testing. We're going to need to test people for both COVID-19 and influenza A and B. We will, however, as things move along, as we do every year, start getting a sense. And there's a point, when you take COVID out of the picture, there's a point in every flu season where our ID docs start saying to the provider community, you know what? You don't even need to keep testing. If they've got flu symptoms, we've got enough activity that you can presume it's probably influenza B. Treat them accordingly. And they watch surveillance numbers then to then say, you know what? It looks like the flu has died down. I think we can take it out of the differential as we go forward. We'll do the same thing this time around with COVID and influenza. I'd almost say it's like we have yet an additional strain of flu in the picture. It just happens to be called COVID-19.
Probably the most important question I'm going to ask you, when should I get my flu shot?
Well, it's a really good question. Every year, the timing issue becomes really an important one. I'll tell you when I'm going to get my flu shot. I'm aiming for end of September, early October. I want to get it soon enough, but not so soon that, I'm not covered by the time I get to the March timeframe. So I think that's the best bet. I'll add one more thing. There is growing optimism that what we're doing as a community and communities all across the country in terms of masking and social distancing is going to have a potentially beneficial impact on influenza. We've never had a flu season where we've done the right thing. We've never had a flu season where we've all been washing our hands and avoiding coughing and sneezing on each other, not coming to work when we feel sick. We can't help but think that the way that we're functioning now, where we're very mindful of those things, isn't going to have some beneficial impact on influenza.
Yeah, COVID is going to force us to take the flu seriously.
Take it seriously.
Instead of saying, oh, well, it comes and it goes,
Yes.
and it's just not a problem.
Exactly right, rather than being cavalier.
Is there anything we haven't covered?
No, I think this has been pretty comprehensive. Yeah.
Well, Bruce, thank you so much for your time. For Dr. Bruce Vanderhoff and myself, Bob Falcone, and the Columbus Medical Association, until next time, thank you.